Hey, BC here for BC Nephro. Today, going to talk about management of hypertension and volume status in the dialysis patient. For the full series, Dialysis Round and Primer series, check out the playlist at this channel and check out the articles at bcnephro.com. Links to both will be in the description below. So, management of hypertension. First thing is, what is the blood pressure? What should we be looking at? The blood pressure is often high, often very high, prior to dialysis. At the end of dialysis, it may be normal or certainly improved. In the middle of dialysis, it may be actually low. So what should we do? As in the general population, the best thing to monitor would be an ambulatory blood pressure monitor, an interdialytic ambulatory blood pressure monitor, or a home blood pressure monitoring on a non-dialysis day. Probably the best indicator. If you don't have that data, use caution in believing everything's okay just because the blood pressure is okay when they leave dialysis. If it's very high at the beginning of dialysis, drops during dialysis, likely several hours post-dialysis, there will be redistribution of fluid from the interstitial to the intravascular space, and the blood pressure may be up again. Be mindful of that. So, how do we control blood pressure? As in the general population, sodium status is key. So just as in the general population, you would give a dietary sodium restriction and you would give a diuretic to achieve a better sodium status for hypertension, certainly for resistant hypertension. The same principles apply to the dialysis patient. So you're going to be counseling on dietary sodium restriction. However, diuretics are not going to work as well. What you're going to need to do is remove the sodium, achieve the sodium status and the volume status with dialysis. So a couple keys here. One is the dialysate sodium concentration should be a little bit low, maybe 137, 138, certainly not higher than 138, because if you have a higher dialysate sodium concentration, you're going to have a positive sodium balance during dialysis. Then the patient's going to get thirsty and their interdialytic weight gains are going to be high. So use a mildly low dialysate sodium concentration to achieve a negative sodium balance. In addition, achieving an appropriate dry weight, an appropriate target weight, and probing, pushing the boundaries for that is crucial. When the fluid is removed during dialysis, sodium is removed by a mechanism called solvent drag. The difficulty is that patients often don't tolerate ultrafiltration. Their blood pressure may drop, they may develop cramping, so this is an issue. And in my opinion, a lot of these cases, you need to ask yourself this question. Is the patient not tolerating it because the dry weight is set too low, which may be the case? Examine the patient, assess for that. Or is the patient not tolerating it because the rate of ultrafiltration is too high? In patients who have hypertension that is not controlled on dialysis, it is often the latter. The main treatment for this is longer or more frequent dialysis sessions. Now, this is difficult to counsel the patient, to get the patient to understand, because they're associating their cramping and low blood pressure at the end of dialysis. So they're thinking if their dialysis session is shorter, that they're going to eliminate those symptoms. I am upfront in counseling the patients that if you're trying to remove the same amount of fluid in a shorter period of time, you're actually going to feel worse, that approach of a shorter treatment backfires, and really encourage them to consider a longer treatment or more frequent treatments. Now, a lot of patients are going to need antihypertensives in addition to the volume control, the sodium control. So here are some things I think about. First of all, try to avoid medications that are difficult to take, essentially medications that make the patients feel like crap. So if you have a TID medication, 3 times a day medication that makes a patient feel like crap, you shouldn't be surprised that if they're not taking it. So things like this, things like clonidine, things like labetalol, are things to try to wean off. I don't think it's reasonable for most patients to take those medications. They may have their role in some patients. But the second thing is consider what medications are dialyzed. So certain common medications are dialyzed. Certain beta blockers, specifically metoprolol, also atenolol, are dialyzed. So use a beta blocker that is not dialyzed. And the one I like to use is carvedilol. Second, ACE inhibitors. Many ACE inhibitors, if not most ACE inhibitors, are dialyzed. whereas angiotensin receptor blockers are not. So if you're going to use a medication, use an angiotensin receptor blocker. Third, calcium channel blockers, specifically dihydropyridine calcium channel blockers, are effective. They're effective in salt-sensitive hypertension and volume overloaded states, which many dialysis patients are. And even though you're trying to achieve euvolemia, you may not get there. Use a dihydropyridine calcium channel blocker. The next thing, which is often effective, and it may seem counterintuitive, is spironolactone. Spironolactone may be helpful in the patients already on these 3 medications, add-on for resistant hypertension in this case. And there may be concerns about hyperkalemia, so watch the potassium. Many patients, the potassium can be controlled, and you can use this as an add-on. So this is my approach to management of hypertension in end-stage kidney disease. If you have any questions, challenges about your management, leave a comment below. Email me at brian@bcnephro.com. If you made it this far, thanks for watching. Like the video, subscribe, and let your friends know. Until next time, thanks for watching.